see some friends already.
Yeah, good to see everybody. If it's okay, I think I'm going to kick us off while we're waiting for people to come in. Everybody's time. Good morning, good day, everybody. Thank you for being here with us for Pillar Talk, entitled Access to Global Surgical Care as a Moonshot with Gail Rosseau. This is part of a series of larger programming that PQMD puts on to address major trends, leading thinking, provocative issues, and best. My name is Julie Marie Vanderberg, and I am here at PQMD. For those of you who may be new to PQMD, welcome. And also I see some old Operation Smile friends. We are a leading global members who represent both the NGO and the healthcare sectors. We're dedicated to access to medicines and the highest quality medical product donation practices. We in 1999, and our work and our members' work is central to health system strengthening and universal health care. Again, thanks for being with us. Can you please go ahead and warm up your fingers? We'd love to know everybody who's here. So if you could put your name and your organization in the chat box, then you can let other organizations know too. And we would like to request that everybody during the program itself. However, we do invite you to utilize the chat box for questions and comments. Our session will be recorded today and be posted on PQMD's Community of Practice. Share that out. And we will share out a link for our Community of Practice. It's a place where you can join together with members and the broader humanitarian sector for timely and informative discussions. Now I have the distinct pleasure of introducing our keynote speaker, Gail Rosseau. Gail is a clinical professor of neurosurgery at George Washington University School of Medicine and Health Sciences, and an adjunct professor of global surgery at Barrow Neurosurgical Institute. She has been involved in global neurosurgery all of her career and is a leader in the global surgery movement. She has authored over 300 peer-reviewed publications and been invited as visiting professor in over 20 universities around the world. She is Global Champions Editor for World Surgery as well. And she's also the chair of the G4 Alliance, which is how we have come to know Gail at PQMD. Our executive director, EJ Ashburn, who should be on shortly, has also been honored to accept a board chair position, a board member for Alliance as well. And as G4 is dedicated in surgical access, not only surgical access, but safe, timely, and high quality around the world, our two organizations are quite well paired. So without any further ado, Gail, I'd like to turn it over to you. And thanks for being with us, everyone.
Well, thank you very much, Julie Marie. It's really a pleasure to be here. Pleasure to know that our organizations do align very well. Let me go to my slides here. Can you see them okay?
Yeah.
You can see those? Okay, great. So we'll get started. So I was asked to, it's always best to talk about the things you know, right? And so I know a fair amount about the global surgery world. I know certainly more about the global neurosurgery world, but there's common themes, obviously, and I'd like to share with you the way we in global neurosurgery think about our initiatives, and perhaps they will provide seeds for conversation and collaborative efforts together. So thank you very much for this opportunity. And let's see. I'm not seeing a way to advance my slides though here, which is kind of odd. It looks like, it's asking me to do a new share. So let me try that.
There you go.
There we go. Okay, good. All right, thank you. I have no financial disclosures. I'd like to thank you, Victoria, and of course, EJ, my friend and fellow board member, for this nice invitation. And in just doing my due diligence before talking with this esteemed group, I noticed a few things from your website that really are PQMD initiatives that really resonate particularly well with those of G4 Alliance. You know, we all want to have impact in the world, and we can get discouraged if we think about how many people don't have access to surgical care and could be overwhelmed with the thought of, well, what can I do? But this impact pyramid really makes sense to me. So I applaud that and join you in thinking about ways to collaboratively from the profit and nonprofit world tackle together our challenges for bringing global surgery to everyone. And then I'm really interested in these modules that you have on education, and plan to use them and promote them. So thank you very much for that. I thought perhaps it's best to start with the definition of global surgery. And this is different from international neurosurgery, which is calling out those people from whatever country who are just experts or real geniuses in any given field who are, we hope will share their knowledge with the rest of the world. Global surgery is a little bit different. And I use here the definition that was coined by my friend and colleague, Ignatius Essene, who's a neurosurgeon in Cameroon. And he defined global surgery as the clinical and public health practice of surgery with the primary purpose of ensuring access to safe, quality, affordable surgical care to all who need it. So it's that public health practice combined with individualized clinical care that distinguishes global surgery from international surgery. It's those efforts that we are making in the public health arena that are so important. I'd also like to say that I think let me go back a minute so we can think about this together. I do think that we in this field, we who care about global medicine and global surgery have acquired a second core professional responsibility. You know, since the time of the Hippocratic Oath, we've all had our primary professional responsibility well known to us, and that is to take the best possible care we can of the patient in front of us. But in our globalized world, I think within the last generation, we've developed a second core responsibility. And that is, if we think that what we do is important, then we must also therefore think that providing support to those who are doing what we do in remote or distant lands is also important. So supporting our colleagues who are taking care of their patients is a second core responsibility of global surgeons. Well, you know, some people who are just learning about this distinction between international surgery, which in the case of neurosurgery has been around for over 100 years. We've been sharing best practices with neurosurgeons from around the world since 1919. But that's different than this tremendous explosion of emphasis on global surgery that is really just since 2015. And why is that? Well, we'd all love to write a paper sometime with the impact factor of the Lancet Commission report on global surgery, which was published in April of 2015. And 1 month later, it led to a unanimous resolution, WHA 68.15, which strengthened emergency and essential surgery and anesthesia care. And this slide contains the take-home messages from that 80+ page report. But the highlights are these: that 5 billion people with a B lack access to even safe and affordable emergency surgery. And that means that 143 million surgical procedures are needed each year, but cannot be done because we don't have enough healthcare workers to do that needed surgery. And it further means that because surgery is more complex and costly than some other medical services, that 81 million people face catastrophic expenditures every year by paying for surgery, including in our own country where medical bankruptcy is the #1 cause of bankruptcy in a wealthy country like the United States. So all of these numbers could be discouraging, yet look at what the Lancet Commission report also did. They did estimate $350 billion US costs for surgical expansion up to 2030, but look at the GDP losses that would be saved if we make that investment. So the point of this report, which was requested by the president of the World Bank, Jim Kim, and I'll say it was Dr. Jim Kim, the first physician to be president of the World Bank, who recognized that we need to make the economic case for investing in surgery. And so they did. And the conclusion, of course, is that surgery, obstetrics, and anesthesia are an indispensable part of healthcare, and that we can no longer afford to allow their complexity or cost stand in the way of making our citizens of every country safe. So we distilled that very important report that addressed all of global surgery to our own smaller field of neurosurgery. There are around 48,000 neurosurgeons in the world. So it's a small slice of surgery. And what we calculated, and that's thanks to Michael Doohan at Vanderbilt, if 5 billion don't have access to surgery, that means 5 to 10 million annual and urgent neurosurgical operations are being left undone because we have a huge additional need for 23,000 neurosurgeons right now, today, to do the emergency and urgent operations that are not being done now. So a huge lift is required, and this is what my specialty is trying to systematically address. How do we create 23,000 more high-quality, well-trained neurosurgeons to do the 5 to 10 million urgent neurosurgical operations? And that could be depressing, right? One could say, well, there's not enough of us. We don't have enough time. We don't have enough resources. We're just a small segment of the community, we neurosurgeons. But here's my hats off. I hope there's someone from Pfizer here. You'll recognize this book from your CEO that I've been using as an inspiration. So Dr. Albert Bourla wrote this book, appropriately titled Moonshot, that described what members of the pharmaceutical industry did when faced with a similar challenge, right? Worldwide pandemic. We don't have a vaccine for it. We forget that we were all somewhat despairing, all of us in the world, because it was being estimated that best guess it'll take 2 years to get a vaccine developed. And then how do we get it transported out and into the arms of people? There is a lot of worry about this. And yet, we surgeons were and remain deeply inspired by you, our colleagues in the pharmaceutical industry, because in 9 months, you made the impossible possible. And this is a great book in which Dr. Bourla talks about the 9 months it took to develop a whole new type of vaccine, right? A messenger RNA vaccine. And that he makes the point that this initiative was led by him in the Pfizer shop. He was the leader, and he's a Greek immigrant. He's the child of Holocaust survivors. And Dr. Bourla is a veterinarian, so not perhaps the person that you would select if you were writing a script for the person to lead the world out of a pandemic. But yet, here it is. And there are other examples, of course, from major contributions from other pharmaceuticals and other people in industry as well. But the point made in this book is that by developing a culture of excellence, courage, equity, and even joy, that inspired people to work harder than they normally do, to go that extra mile. And that's what allowed that moonshot to be achievable and probably saved 5 million lives. So I'm inspired by space, by the idea of Moonshot. So I've keyed this talk to you around the famous Moonshot speech that President Kennedy gave at Rice University in 1962. That's where this sort of colloquialism about moonshots came from. And so in this next series of slides, the words that are in italics are Kennedy's own words from that speech. And I've put in bold, just for our purposes, the words that address themselves to healthcare rather than space exploration. So Kennedy said, while there is strife, prejudice, and national conflict in the world, these should not exist in healthcare, which provides endless opportunities for peaceful cooperation. But why, some say, should we care, and why should we choose, in my case, global neurosurgery as our goal? So I'm going to play for you. I hope you can hear it. This is the minute and a half or so of that speech.
We choose to go to the moon in this decade and do the other things, not because they are easy, but because they are hard. Because that goal will serve to organize and measure the best of our energies and skills. Because that challenge is one that we're willing to accept, one we are unwilling to postpone, and one we intend to win.
Great Boston accent, a little bit of nostalgia there, but I personally find that concept and his words very inspiring, as do the people in my neurosurgical community. So let's drill down on it. Kennedy said, we choose to do this, not because it is easy, but because it is hard. You all have hard jobs. You don't shy away from things because they're hard. In fact, the hard is a little bit of the attraction to it. This goal, this global surgery mission that we have, will serve to organize and measure the best of our energies and skills. That challenge is one that we are willing to accept, that we are unwilling to postpone, and which we intend to win. Kennedy went on. He said, we cannot be deterred. I would add no specialty and no nation which expects to be a leader can expect to stay behind in the quest for the highest quality health for all its people. And our instruments in achieving that goal must include shared knowledge, as well as advocacy for enlightened scientific and social policy. And of course, advocacy is what the G4 Alliance is all about. So I take inspiration, and I hope you will too, from JFK and the space program. He spoke in that speech about our vast scientific knowledge. Well, I don't need to tell you all about vast scientific knowledge in Pfizer, Merck, J&J, and time limits me from naming all of you, but huge, huge reservoirs of vast scientific knowledge and rapid progress, and I would say mental strength. And Kennedy concludes by saying, this unanswered challenge and the unfinished work this represents must stimulate our collective energies and resources, and indeed our imagination. So that's why I believe global surgery and global neurosurgery is our moonshot. So let me now drill down and share with you some of the things that surgeons and surgical organizations are doing to try to get us on the moon, right? To try to get us to that place where we do have the ability to provide high quality, affordable surgical care to everyone everywhere. That will be our moon landing. So our shared knowledge now, silver lining from the pandemic, we have educational programs online, and I've not encountered a neurosurgical program yet that doesn't have access to the internet. In fact, when we were working with our colleagues in Afghanistan, our step one was we got them internet access at all their hospitals so we could then move on to step two, which was sharing knowledge. We have simulation, and it has increasing fidelity. And now we're starting to see some neurosurgical procedures that are better taught on models or simulators than on cadavers. We have new healthcare delivery systems and partnerships. We have new field clinics and hospitals. I could go on and on, but I want to share with you just two specific neurosurgical things that I think are important new developments. The first is expanding our training and skill set. So what we've realized when we recognize we have this second core responsibility, that was a professional responsibility, that we needed to share our knowledge with other providers of neurosurgical care, is we need public health training for our neurosurgeons so that every resident who graduates from one of our North American programs will not only know how to do the operations well, but they'll also know the situation for those domains of the public health for which we have primary clinical responsibility. And although we're a small specialty, our specialty touches a very broad swath of public health. So think traumatic brain injury, spinal cord injury, stroke, hydrocephalus, degenerative spinal disease, metastatic disease to the brain. And then you're talking about somewhere around 20% of the global burden of disease. So it's huge, and we are ramping up so that we can not only be clinical experts, but provide some help to the public health leaders in our countries. The second thing we identified during the pandemic was, let's call it a disruptive innovation for ways of training neurosurgeons, and that our traditional model, which has served us well, it's the Halstedian model developed at Johns Hopkins, which is a master and apprentice model, which is what our residency programs are. And those have proven to be very high quality, high fidelity ways of training a neurosurgical workforce, but they are also very expensive and very slow. It's very hard to have 23,000 eager young minds at your elbow while you're doing operations, and that's been our master apprentice model. So we are now have grant applications sitting with NIH for very disruptive new ways of doing this, which would involve online collaborative cohorts that are high income country and low and middle income country, program directors and students using reverse classroom, or you can call it Khan Academy or Harkness method teaching online, and then using online simulators, coalescing at the end to, or I should say culminating at the end, to travel to as a group to those places where high volumes of these cases are done. And in the examples of traumatic brain injury or spina bifida, the high volume centers are not in North America. We want to see high volume in order to be able to be good at what we do. We're going to have to travel to and learn in a low and middle income country, and that will become the standard for best practice and best training. So those are just two emerging global themes in my discipline that came out of the pandemic. Other instruments, arrows in our quiver for how we might close the gap between where we are now and achieving universal access to quality neurosurgical care. Well, our journals have really stepped up to the plate. We have a number of journals. These are the top ones, and they are all addressing global neurosurgery in a big way. So World Neurosurgery has multiple global publications by global authors, HIC, LMIC. There's a running column called Doing More with Less, which, by the way, doesn't only benefit those countries that have resource challenges, but it also ultimately helps us. You know, there's some countries like Nigeria that spend 0.5% of their GDP on healthcare. And we know that's probably too little. But in our country, where we're spending 16 to 18%, but we're not in the top percentage of quality of health, we maybe are spending too much. And so right sizing the way federal sovereign budgets appropriate money to healthcare is something that we can learn something from if we think bidirectionally in the way we go forward with this. I'll share with you the Global Champions Program, and our first publication on that is in the lower left. We looked at medical publishing in general and said, isn't it a shame that there are two inequity problems here in medical publishing? Most medical publishing, as you all know, is in English, and that raises two problems. One is if the metric for how to get ahead in your field is to publish in English, then those who don't speak English as their native language, nor do they have access to native English speakers, are really at a disadvantage. The second thing is that it's not just native Anglophones who have good ideas. And so the profession itself loses out on good ideas if we don't find a way that people who are not native Anglophones can have their ideas and their experience published. So at World Neurosurgery, we started something called the Global Champions Program and developed an editorial board that would help with this. So instead of just the standard categories of accept with revisions, reject, we now have a new category, which is reject with recommended referral to the Global Champions Program. And those authors can then send their paper to us, and we don't rewrite it for them, but we do track changes and suggested edits. And in that situation, what this paper showed last year is that 40% of what was previously rejected is now accepted. So my understanding from Elsevier, which is the publisher of World Neurosurgery, and they are the publisher of 2,500 journals in the medical literature. My understanding is that this is the only such program. So we certainly hope that other disciplines will follow suit. And we are looking at whether this can be done effectively by AI. And so that's the next study that we're working on now. The other thing that we did during the pandemic was we and you can see the illustration from that publication on the right. We looked at all the countries that had published neurosurgical outcome papers, and in order to understand what the outcomes were for different diagnoses within the neurosurgical burden of disease. But we found this map to be interesting because we mapped out, well, the negative space of that study was that there were 15 countries that either had 0 or just 1 neurosurgical outcome study. So now what we're doing is going individually in systematic and targeted fashion, working with collaborators in those countries in order to flesh out what neurosurgery looks like there, so that we will truly have an accurate picture of global neurosurgery with every country on earth contributing. Journal of Neurosurgery, one of our big journals, is a publishing group with 5 journals, and the neurosurgical focus part of their stable of publications is thematically organized. And so in recent years, they've had 3 neurosurgical focused editions that are specifically targeting neurosurgery, reducing inequities, international education, and one I'm quite pleased with and edited, the International Women Leaders in Neurosurgery. And then we have what we call the Red Journal, simply named Neurosurgery. It's the highest impact journal in neurosurgery. And in the end of 2022, Neurosurgery actually created a section of global neurosurgery. So just like the other 6 or 7 sections that you might anticipate we would have, so tumors, spine, peripheral nerve, cerebrovascular, pediatrics. Now we have a global neurosurgery section. I'm delighted and honored to be the editor of that section, and you can see we use the moonshot analogy there. And then using bibliographic metrics, we selected senior and junior associate editors from each of the 5 continents so that we have broad representation, both geographically and generationally. So what other instruments do we have? Well, advocacy, and this is where, I put on my G4 Alliance cap because we are the advocacy organization for SOTA care, surgery, obstetric, trauma, and anesthesia care. And we work toward enlightened scientific and social policy. So I'll give you a few examples of that. We already talked about 2015 when the World Health Organization responded to the Lancet Commission report and passed the resolution that strengthened emergency and essential surgery that really, put us on a different trajectory, all of us, in terms of integrating global surgery into our daily work. And just last year, I'm happy to report that surgeons also led the way for something that was, again, very important, but very different, and that is prevention. So a folic acid fortification resolution was passed in order to prevent the 300,000 annual cases of spina bifida that are born largely to impoverished mothers in impoverished nations. Also, the pandemic showed us that oxygen supply was critical and should be looked at as a critical medication. So we helped with the passage of the resolution to work toward guaranteeing adequate oxygen supplies. And then finally, we broadened the definition of surgical care from 2015 to include emergency, critical, and operative care. So the so-called eco care. So that's not ecology, although we need to be mindful of green OR practices, but that stands for emergency, critical care, and operative care, because those are really the disciplines that require the same infrastructure in a healthcare system in order to be able to provide care. And then from this, because these are such important initiatives that affect all of our practice, we in neurosurgery publish in our peer-reviewed literature each year what neurosurgeons did at the annual WHO meeting. So here's an example of our paper from last year published in Neurosurgery, Progress and Resolutions at last year's World Health Assembly. And we're already writing the outline for what will become this year's publication after our meeting at the end of this month in Geneva. So our instruments include advocacy, and here I must mention the G4 Alliance, and I'm sure that Elizabeth Ashburn, one of our board of directors, won't mind if I do. There are now approaching 80 organizations in our federation. So the G4 Alliance is a federation of organizations that exist to work toward providing surgical care. So you can see some of them that are large that you recognize. So Mercy Ships, St. Jude's Research Hospital, Research, World Surgical Foundation. And then I've listed on the left the ones that are specifically directing their efforts toward neurosurgical care and neurosurgical advocacy. So that includes the Congress of Neurological Surgeons, so 8,000 neurosurgeons from around the world, Foundation for International Education in Neurosurgery, Intersurgeon. I would encourage all of you to go on your mobile phone and look up intersurgeon.org. There's a mobile app. It's powered by the G4 Alliance, and it's been said to be analogous to Tinder for the global surgery world. It's a way for people who have things and people who need things to meet one another online and then develop whatever their specific partnership could or should be offline. So please look up intersurgeon.org .org, and it's not just surgeons, it includes the burn community, the nutritional community, and nursing, and so forth. So it's surgeon in the broadest sense of providing surgical care. Barrow Neurologic Institute, and multiple universities, Alabama, Northwestern, Harvard isn't even on this list, but the Harvard Program in Global Surgery and Social Change, Solidarity Bridge, which functions in Latin America, Bolivia and Paraguay. Think First, a prevention organization, Corlebu Neuroscience, functioning in Sierra Leone and Liberia, St. Jude Hospital Foundation all over the world, the World Federation of Neurosurgical Societies, representing 130 societies, and recent additions, the Society of British Neurosurgeons and the Tanzania Neurosurgical Society. So what we do as an advocacy organization is that we foster the relationships of our members with these large multilaterals or global organizations. So at WHO, for instance, we work on resolutions, on operative registries, on the surgical hub, which is an educational format. We're working with them on how to best develop quality healthcare workforce and professional accreditation. We have Minister of Health Relations that are often created and reconnected and solidified at the annual meeting of the WHO called the World Health Assembly in Geneva, and that starts in just 2 weeks. The UN General Assembly, our tagline there has been, we need to suture the gaps in healthcare by making sure that all of the leaders of the world are thinking about surgery when they're thinking about global health. So we need to be thinking about climate change. We also need to think about defense of science. And we are surgeons, but we are deep defenders of the science of vaccination, for example. And the World Bank. So there we go to their spring meeting each year and help to create and participate in dialogues to build bridges to major funding, the pandemic fund, the new types of blended financing between government organizations and NGOs, between for-profit and not-for-profit organizations. And then we're a member of ECOSOC, and that's the social community under the United Nations that allows us to reach out to other members of civil society. So here's some of our reports from the World Health Organization. Now, I should say that this is very low budget. Neurosurgeons go on their own nickel and on their own vacation time. We don't, as societies, support this travel with funding, but we support it wholeheartedly as a concept. I want to bring your attention to a partnership of the G4 Alliance and the International Society for Pediatric Neurosurgeons that in 2019 formed this group called GAPSPIF, the Global Alliance for the Prevention of Spina Bifida. And it was the role of neurosurgeons in global public health that we were writing about in 2019 that we then wrote again about in a landmark article in The Lancet in 2022 that led to that resolution in 2023 on folic acid fortification, which is set to be able to prevent 300,000 births of patients with spina bifida. Now, we also do advocacy with the U.S. government. So I see that some of our colleagues are on the phone here. Michael Nebeker, for example, with Mobile Surgery, who led the way here within the Resource Mobilization Committee of the G4 Alliance toward getting language in the U.S. budget that requires investment in global surgical conditions, including trauma. And already Congress has mandated that the U.S. AID report on already dispersed funds on how those funds will be used for the purposes of advancing global surgery. This is U.S. soft power. And the G4 Alliance and the Global Surgery Foundation, which is Geneva-based, we work together to inform USAID and our government on implementation. So we do have resources. We've got the NIH, who cares deeply about equity, and increasingly that means having collaborators who are from low and middle income countries. There in the center, you see a group that's, walking the halls of the Senate. You see the Nebekers, Michael and Liz Moore from the G4 Alliance. You see next to them, third from left, Henry Ford, who's the current president of the American College of Surgeons, and on the far right, Gurmit Tefera, who runs the ACS Operation Hope. These are all people who are surgeons who care deeply about working toward a line item in the U.S. budget that will provide direct funds to global surgery efforts. And I've mentioned the spring meetings of World Bank and USAID. At my own institution of GW, George Washington University in Washington, D.C., we have 2 NIH grants that focus on our work in Zambia. One is to create a traumatic brain injury registry so that that high number of incidences of traumatic brain injury, which is a huge public health problem there and in most countries in the developing world. So those can be tracked, because those things that you can measure, you can address and you can fix. So anyway, we have a grant to help them set up their registry, as well as another grant to help them look at the impact and including costs of traumatic brain injury to Zambia over the course of the lifetime. And then our GW Equity Institute, a new program housed within the provost's office, gave us a seed grant to study the effects of colonialism on surgical training, and what are the best ways, what are those pressure points for developing systems of surgical training that improve quality and reduce or eliminate brain drain. And then we have examples from just north of the border. If you know Canadians, they're nice and they have a lot of good ideas. And this is an example, and so far the only example I know, it's from the University of Toronto, where they have a pathway to tenure as a surgeon in global health. So like any other subspecialty of my discipline, cerebrovascular, tumor, pediatrics, now at the University of Toronto, using the same kind of strict metrics of academic productivity, one can become tenured as a full professor who's a surgeon in global health. And I understand they have 6 individuals now tracking through this professional program at University of Toronto, including not only neurosurgery, but orthopedics and ENT. And then we need to be smart about benchmarking and sharing benchmarking. We need to have SMART goals. So again, the need is so large, we could easily become overwhelmed. So what we do in global neurosurgery, and our focus right now, is on those 20 countries that have no neurosurgeons, not a single neurosurgeon. And so we're trying to amplify access of those individuals who are largely general surgeons who are doing simple neurosurgery. We want to align their activity with regional societies of neurosurgery so there can be proper education and task sharing. We want to do that in a way that shares best practices, so advance relevant research. We want to assimilate neurosurgical capacity so that across borders we're able to provide those countries where there are some neurosurgeons can help in those places where there aren't neurosurgeons to bridge the gap, so that at some point we want every person who has a neurosurgical problem to have it addressed surgically by a properly trained neurosurgeon. But we recognize that in this interim period, we need to take responsibility for those patients by helping our colleagues who are rendering care to have the knowledge that they need to provide high quality care. And we need to advocate for universal health coverage everywhere. So as I begin to close, I would say that global neurosurgery, for us to succeed in our moonshot, we need seasoned members of the community in order to show by example that this is important and that this is indeed part of our professional responsibility. So to that end, we've addressed those senior members of the neurosurgical profession by writing in our peer-reviewed journals about encore careers and how people who are starting to look toward retirement, or at least toward slowing down their operative schedule, perhaps not being required to take emergency call anymore, can be those people who help support education of neurosurgeons in the developing world. But the strongest and best and fastest arrow in our quiver are our young people. And here's just a small fraction of the huge number of outstanding young people from around the world in whom we need to make investments of time and treasure in order to help them see farther and go farther. So with that, I'll leave you with a launch, because who doesn't like a neurosurgical launch? This is Apollo 11, which, as you know, landed on the moon
We have
in 1969.
past the hour. Liftoff on Apollo 11.
Who doesn't love that? So if JFK and NASA can do it, so can we. Thanks very much.
Thanks so much. That was just brilliant. That was really interesting. And we do have a question in our chat for you, which is, with training new neurosurgeons, how do new trainees overcome lack of infrastructure to support their procedures and post-operative management?
Well, that's a very good question. And the answer to that is going to take a village, right? So I'll give you a very specific example that I know a lot about. So Barrow Neurologic Institute, where I hold a professorship in global neurosurgery, is partnered with Kilimanjaro Christian Medical Center in Moshi, Tanzania. And so what does that look like? Well, that partnership has involved a commitment to always have a board certified American neurosurgeon there supporting the work of the single fully trained Tanzanian neurosurgeon who is there, as well as a fellow. So there's a core group who are able to provide education, and then rotating in and out are residents from Barrow and eventually beyond, med students from Barrow and beyond. But we work with our educational partners and our vendor partners to be able to help them with supplies. So they now have a Zeiss operating microscope. That's through partnership and leverage with Zeiss, who provide lots of microscopes in Phoenix and help with the provision at low cost of microscopes in Tanzania. Likewise for surgical endoscopes, likewise for all of the equipment that we need. And we look forward to developing more vendor relationships. We also work with other foundations. So there's a foundation called the Foundation for Cancer Care in Tanzania that is based in Minnesota, and they're oncologists, so medical oncologists, but they care deeply about the lack of radiation therapy, as we do, that follows the removal of some of our malignant tumors. And so that group was able to focus on getting radiation therapy and stereotactic radiosurgery platforms. So the build out is happening now. I've actually been in the 4 bunkers that are under construction, and in Q4 of this year, a LINAC will be delivered. We hope it will be operational in Q1 of 2025, and that's happening in concert with a blended vendor academic model for training neurosurgeons, radiation oncologists, and medical physicists as teams in sub-Saharan Africa. And so obviously, that's a long answer, but a detailed answer to the question about the resident. So we do not currently have a residency in neurosurgery. KCMC has a residency in general surgery, but I'm happy to say the first general surgery resident who trained at our institution is now a first-year resident in Dar es Salaam, which is where the only residency is. And we have a site visit in August to become a residency training site. I'll also give a shout out to that individual. He's pretty extraordinary. He's a Maasai who's now training is a general surgeon training in neurosurgery, who just won the first ever G4 Alliance Global SOTA Award. So it's a cash award for outstanding contribution from a frontline healthcare worker in surgery. I hope that answers the questioner's question about that.
Very much so, and I think inspired another question, which is, can you talk more about cross-training general surgeons and neurosurgery?
Sure.
Do you find that surgeons in other countries are more open to practicing outside a single specialty than you might find in the US?
Well, it's impossible in the US. You can't get privileges if you're not certified in your specialty. But that's a luxury that we can afford to have because we've got plenty of surgeons in every discipline. But yes, if you look up Robertson et al., Faith Robertson is a resident in neurosurgery at MGH. I've published with her on this. She's looked at specifically at task sharing versus task shifting in the Philippines, and it works very well if it's done systematically. And of course, we now have this great opportunity to use the internet to be able to share not only images for surgical decision making, but we've got all kinds of platforms that allow us to be able to help those who we've trained then walk through difficult cases in real time, but from a distance.
Great. So much. Thank you so much. I know that you do have to jump a little bit early, so I just wanted to welcome EJ Ashbourne, our executive director, to give some closing remarks. EJ, are you there?
Hi, Gail. Hello, everybody.
Hi, EJ.
Thank you so much. I just am listening to your lecture. I was just thinking to myself, how lucky are we to have someone so eminent and somebody who not only is an expert, obviously, in the field, but also who really goes to the front lines of all of the countries talking about, and really not only serves the people in low middle income countries, but does so not from a distance, but from right up close. And I just think that that does bring you, that brings incredible perspective to the idea that you, first of all, you think about a moonshot, and then the idea that their possibility can really exist. And so I'm just, and I've gotten just to be transparent, I've gotten to know Gail through being on the board of the G4 Alliance, which she chairs so amazingly, and how lucky for that organization to have you at the helm as well. So I did just want to say thank you so much for spending this time with us. I know you have to run off to teach, I don't know, brain trauma to med students because that's what you do on a daily basis, along with all of the other incredible work that you do. I think you inspired a lot of interesting questions and things that we can continue. We certainly, as PQMD, our members are partnered with centers of excellence all over the world, particularly in low middle income countries and elsewhere. And where we don't partner with them, we build them. So, and we build them through alliances like with the G4 Alliance, but also within the programs of our different international nonprofits, and certainly supported and engaged with by our corporate members as well. So I just want to say, we look forward to continuing this conversation, to continuing to hopefully participate in those really big ideas, with the idea that it is absolutely possible. So thank you very much on behalf of all of the members of PQMD, all those that are not members of PQMD who joined us today. We're very happy that you were able to come and listen to this lecture. I hope you'll come again for our other programs. And thank you and have a great afternoon.
Well, thanks very much. I put my email address on the last slide, and I'll just say if there's anyone, anyone who wants to follow up on any of these issues that I raised, feel free to reach out to me directly. And as EJ knows, because she's led the charge, the G4 Alliance has not only other academic and nonprofit organization members, but we now have for-profit companies as vendors as well. Corporate membership is available. And we know that the trend in global health is toward public company, private partnership, government organization, NGO organization. So we're eager to seek out and work with all partners who care about this moonshot.
Thank you so much.
Thanks so much.
Thanks
Have a good
everybody
day,
for
everybody.
joining.
Thank
All right.
you.
Thank
All right.
you.
Have a
Thank
great
you. Bye-bye.
Bye-bye.
Bye.
Thank you.